Good afternoon, everyone. My name's Hope Frost, and I'm delighted to welcome you to this webinar on behalf of SBK Healthcare. Today's webinar is Adapting Your Diabetes Pregnancy Service during COVID-19, and we do hope that you find it useful and you enjoy it. I would like to thank Advanced Therapeutics and Agamatrix for kindly sponsoring this webinar. So it's now my pleasure to hand over to Sarah Hartnell, who is a Principal Diabetes Dietitian at Cambridge University Hospitals NHS Trust. Hi, Sarah.
Hi, thanks, Hope. Just going to share my screen. Okay, so I'm literally going to give you a whistle-stop tour through closed-loop insulin delivery in pregnancy during COVID. So, and specifically talking about the CAM APS FX system, because that is the only closed-loop system that is licensed in pregnancy currently. So just to make sure everyone's on the same page, we're talking about closed loop, also known as artificial pancreas, also known as automated insulin delivery. And whichever system you look at, it will all run with the same items. So everyone will be needing to wear a continuous glucose monitor or sensor of some description. Everyone will be needing to have an insulin pump of some description. And the system will require some kind of control algorithm. And for some pumps, that will be embedded in the insulin pump itself, but for the system I'm talking about, the CAM APS FX, the control algorithm is embedded in an Android phone app. So the system particularly lends itself to kind of a COVID era, if you like, partly because of its ability to have remote uploading, remote reviewing, and we have a system of remote training as well, which we found really useful to mean that we've really been able to reduce the footfall. Patients have been able to come into say for the clinic for their scan and go again, and then we've been able to do everything else we've needed to virtually, which has been really useful over the last few months. So the specifics of our system is that, as I said, the control algorithm, the Cambridge algorithm, is situated on an Android smartphone, and that links with a Dexcom G6 sensor by Bluetooth, which also, and the phone also links with a Dana RS or Dana I insulin pump, again via Bluetooth. And as you can see, the data flows automatically to the DiaSend platform, which most of you will be familiar with. And so it gets away of having to have any uploading. No one has to come in and or try and manually upload pumps or meters. It does it remotely as long as you're attached to the Wi-Fi or you've got a SIM card in your phone, sorry. Just to make it clear, currently all closed loop systems are hybrid closed loop, so you still have to bolus for meals. Insulin's just not fast enough to get in quick enough and deal with post-meal glucose rises. And so we still do need to encourage people to bolus for meals. And these are the sorts of things you see on the DiaSend data. So the top, you can see the glucose trace there. For pregnancy, we'd be aiming for the slightly tighter targets of 3.5 to 7.8 in the green band. And then you can see when someone boluses for carbohydrate containing meal, which you can see the triangles are the little carbohydrate containing meals, and below you can see all the insulin delivery. So you can see normally the system will be automating the basal insulin delivery depending on the rises and falls in blood glucose levels. So if the glucose is rising, it will deliver a lot of insulin to try and mop up. If it's falling, it will back off and deliver nothing at times. And you can see these blue bars where the bolus insulin is being given bolused by the person as they eat the meal. This system has come out of over 15 years of clinical research. There's lots and lots, a whole wealth of randomized control trials, really high quality data in all ages and ranges of people with type 1 diabetes, including some studies specifically for pregnancy. And the specifics of the system is that, as I said, the app houses the Cambridge model. The app therefore also acts as your CGM receiver. So the Dexcom G6 is specifically embedded within the app. So everything that you would usually see with the CGM in terms of alerts and alarms are available on the system. And the app also incorporates a bolus calculator. So although the Dana insulin pumps have their own internal bolus calculator, you do all your bolusing from the phone itself, so it makes the pump discreet. You don't need to be getting the pump out to give a bolus. You do everything via the phone by pressing the little knife and fork icon at the top there that you can see on the home screen. And as I said, all the data is automatically uploaded to Diasend, and that's what's been so useful in terms of being able to remotely review data for these women more recently. The other thing that's useful with this system is there is the ability to have real-time SMS alerts. It's more useful when young children are using the system, so not so much in pregnancy, but it's still a feature that's really helpful. So in terms of the algorithm, this is what you see when you turn the phone on its side, and it gives you all the data that you might want to know about what's been going on with your insulin delivery in the past sort of few hours, and you can skim back through that. So you can see it's the same data I showed you on the Diasend graph, but just displayed in a slightly different way there. So you can see the target range is this grey area here, and you can see the glucose in the unfilled and filled circles. They fill when you're in target. The basal insulin delivery that the pump is delivering is shown in these the dark blue lines, and you can see how it modulates depending on the glucose level and how much insulin is required. And you can see where boluses of insulin and carbohydrate have been entered into the system. The system is really simple to set up. All it requires is body weight and total daily dose. And then from then, it's an adaptive and predictive system. So it takes into account the daily, diurnal and post-meal insulin needs and constantly adjusts and modulates depending on what's required. All those settings are independent of the pump, basal and carb ratio and correction factors. The system calculates its own active insulin time, its own sensitivity for different times of the day. And then we'll give this different basal insulin dose every 12 minutes via a short extended bolus, depending on what the glucose levels are doing. And it has the ability to be personalized to a high level, which again is why it lends itself really well to pregnancy. So whereas some other closed loop systems only have fixed targets that might be a little bit too high for pregnancy, there's the ability with this system to set much lower targets, so between 4 and 11. So we normally, for our pregnant women, we start in the early stages of pregnancy with a target of 5.5 and then drop it to 5 or even lower as their pregnancy goes, depending on the glucose variability. And there's a couple of key functions with this system that are really useful too, including boost and ease off mode. So a lot of people are familiar with increased and decreased temporary basal rates on normal pump therapy. This is exactly the same, except a cleverer version. So boost will boost your glucose if you're above target, but if you drop back down into target, even though boost might still be running, it won't continue to deliver additional insulin. If you start to rise again above target, then it will deliver additional insulin while it's still set. And ease off mode is really useful again for periods of activity. So you can preset both those functions with this system as well, which can be helpful. For example, if you know you're going to go for a swim at lunchtime, you can preset ease off to run kind of an hour and a half to come on an hour and a half before your activity. So you're in a position where you've got less active insulin around at the time you're going to be most active and most sensitive to that insulin. And lastly, the thing that makes this a really useful system in a COVID era, as well as the ability to virtually review and all the remote automated uploading, is that we have a whole system of virtual training and support. So via the CamDiab website, there's a training button, and if you click on there, you can register for training in all the devices. So pump, there's also going to be a training module on Dexcom G6, and there is training on the app itself, and as well as all the things you would expect from a company in terms of support and online training and recorded webinars. So that's all there available for you. And I think that's my last slide. So I'm going to hand back over to Hope and stop sharing my screen to carry on.
Thanks, Sarah. That's brilliant. And Sarah's going to be saying for questions at the end if you do have any for her. So now it's my pleasure to introduce Dr. Paromita King, who is a consultant physician at the University Hospitals of Derby and Burton NHS Foundation Trust. Hi, Paro.
Hiya.
Perfect. So Para's going to share her slides for you.
Good afternoon, everyone. I was asked to describe to you some of the developments in our diabetes and pregnancy service, and I've decided to entitle my talk as a tale of 3 challenges. But to start off with, just to remind you where we are. So Derby is classed as being in the East Midlands. And in our area, we serve a greater population of 600,000, handle around 6,000 deliveries a year, 60 of whom have got pre-existing diabetes and 500 gestational diabetes. I'd imagine if I'm using this slide next year, all the numbers will begin with a 6, because as we know, there's a huge increase in gestational diabetes. I think Derby is regarded as quite an insignificant stop on a railway journey in the days that we were travelling by train. But did you know that in 2011, the Lonely Planet magazine listed Derby as a top 10 must-see destination? This was alongside places like Goa, but was really because the Good Beer Guide in that year named Derby the first city of beer. Now, by coincidence, in 2011, we started the first of the challenges that I'm going to talk to you about. So this was improving the uptake of preconception care. Secondly, I'm going to talk to you about how we were dealing with increasing numbers, particularly with gestational diabetes, and then spend some time talking to you about how we've kept women safe during the COVID-19 pandemic. So I've asked you to conjure up some images of infants born to mums with diabetes. These are the sort of pictures that you will be coming up with. The baby on the left has sacral agenesis or caudal regression syndrome, which is the type of neural tube defect that's specifically associated with diabetes. On the right is the more familiar picture of the macrosomic plethoric baby who may be born on time but display many of the complications of prematurity. So 6,500 pregnancies a year in people with pre-existing diabetes, and we know that effective preconception care can reduce the risks. This is a largely specialist audience. I'm not going to list the components of preconception care. I'm sure you're familiar with them, but just to remind you of how powerful a teratogen glucose is. So this is data from the Northeast. On the x-axis, we've got HbA1c in old money, and the y-axis, you've got congenital abnormality rate. And you can see as soon as HbA1c starts to climb above the upper limit of normal, there's a linear association between HbA1c and congenital abnormality rate. So it's not surprising that NICE are recommending that we aim to get the HbA1c at the upper limit of the non-diabetic range, less than 48, if it's safe to do so. And it's over 30 years that we had the evidence that improving glucose control can reduce congenital abnormalities. So we'd hoped in 2002 to 3 we would start to see improvements. The Confidential Inquiry into Maternal and Child Health undertook an audit of pregnancies in type 1 and type 2 diabetes in England, Wales and Northern Ireland. And we were all shocked to find that only 35% of women were accessing preconception care. And these women had babies with a 4-fold increase in congenital abnormalities and were 5 times as likely to experience a stillbirth in a woman without diabetes. And moreover, there was marked variation from unit to unit in terms of service provision. So at this point, a number of task and finish groups were set up nationally. Some of you may recall them. I was involved with one that involved looking at the preconception pathway. But this is where the National Diabetes and Pregnancy Audit came from, which of course reported last October. This also showed there'd been very little progress since the CMATCH audit, with only 8% of women being adequately prepared for pregnancy, as defined by having an HbA1c of less than 48, conceiving on high-dose folic acid, and not on any adverse medication. The graphs below give you the year-by-year data, with the percentage that were adequately prepared on the y-axis. The blue bars represent type 1 diabetes, and the grey bars type 2. You can see there's no consistent difference between type 1 and type 2, but what's more disappointing, no changes over the years of the audit. So that was the national picture. What about locally? Well, back in the days of the CMATCH audit, we were providing some preconception care, but within our antenatal clinic setting. We're seeing about 1/3 of women beforehand, so much the same as the national average. But we had a congenital abnormality rate of 10%. And stillbirths, although it's hard to say because the numbers are small, a rate of approximately 6%. We were also aware that when we were seeing these ladies, around 20% of them weren't coming back. So we started to talk to them. And they described how stressful an environment an antenatal clinic was to be sat in if you weren't pregnant, particularly if you'd had a miscarriage or were undergoing infertility treatment. Obvious perhaps, but it was a factor that influenced the non-attendance. They also explained how difficult it was logistically to attend these appointments. One pointed out, when we were planning pregnancy, we're not discussing this publicly. There's enough appointments to attend already. It'd be much easier if we could be seen nearer to our place of work or home, where we could nip out at lunchtime or pop in the beginning or the end of the day. So that's the point. I thought, well, if you are going to spread the model of preconception care more widely, how is I, at that time, the only physician that was supporting the service, be able to see the patients that we needed to see? So I thought, well, I remembered Florence Nightingale quoting, saying, let whoever is in charge keep this simple question in their head, not how can I always do this right thing myself, but how can I provide for this right thing to be always done? So with this in mind, I thought, well, maybe we can deliver services out in the community. And we applied to the Health Foundation for a grant, and were given one of the Shine Awards to be able to pilot a different way of working that would better meet our users' needs. And from this came Proceed, Preconception Care for Diabetes in Derby and Derbyshire. This had two components. Firstly, raising awareness of the need for preconception care, not just amongst the people with diabetes, who we would mention at every opportunity and sent them all leaflets on the subject, but the professionals that were in contact with women of childbearing age. And this would include people like pharmacists, infertility clinic, family planning clinics, as well as GPs and practice nurses. We asked their help to use every opportunity to discuss pregnancy plans and document contraception. And if they were planning pregnancy, then to refer them to the preconception clinic Proceed. And our ethos can be summarised by 6 C's. We worked across organisational boundaries using all competent resources. So for example, if we had a colleague who was working the antenatal clinic with us, but now was predominantly out in primary care, we would ask for their help in engaging some of these women and providing the care. We were able to provide choice in community-based venues and as much as possible flexibility in the appointment time. A member of the antenatal team was working in each Proceed clinic, which meant that there was consistency of information given, and we provided continuity of care from the preconception to the antenatal period. It's a stressful business, and to see a familiar face makes all the difference. And I adopted my Florence Nightingale approach to this model, which is I didn't see everybody that came through the door, but concentrated on those at the highest risk. Meanwhile, every couple of weeks, I would run through all the patients that were under our care to maximise quality of the service and to provide mentorship for my team members. So what did we achieve? At the end of the first year, we were able to demonstrate quality improvement across 7 domains of quality. For example, we doubled the numbers that we saw. Our failure to attend rates dropped from 18 to 5%, and waiting times from 13 to 5 weeks. HbA1c in the people that were attending was significantly lower than those who didn't, 54 versus 76 millimoles per mole. We saw 70% of women before pregnancy in that first year. Congenital abnormality rate dropped from 10 to 4%, and we saw no stillbirths. Financial savings purely as a result of reduction in length of stay and reduced appointments was 68,000, and our users described this as first class. I'm hoping I'll be able to show you a few words that the users have to say about this now.
With me having depression and having to sort things out before getting pregnant, as well as being diabetic, going somewhere like that, talk one-to-one with the doctors and the nurses and whoever helps, it was a lot easier, and it made me feel a lot calmer, and dealing with all the issues before getting pregnant and now pregnant, it just put us both at ease.
When I went to the fertility unit initially, I did ask them if I could be referred to a specialist, and I didn't really get a reply. And that's when I went to my doctors and spoke to my nurse, and I got seen by Dr. King that week. If I hadn't have had that support, then, well, God forbid what would have happened, but you know, they just, when I was feeling like I couldn't carry on with it, they were there to help me.
I just want to say how much more convenient it is for us diabetic want-to-be mothers who work full-time to have support out of hours and also by email. I work 9 till 5 days a week, and when you're trying to keep it quiet at work that you're even trying to conceive, it is more than helpful to be able to speak with someone after work, via email and also over the telephone.
I know that a lot of women with diabetes don't plan pregnancies, and I can understand why. There's a lot to worry about between blood glucose levels and the worry about complications such as heart defects, neural tube defects and stillbirth. However, the close contact that I've had with Dr. King and her team have transformed my experience from a potentially very stressful one into an enjoyable one. They run a first-class service, and I felt very privileged to be part of that service.
So strong praise from our users. And I will go back to sharing my screen with you, I hope. I think one of the questions that we had was, is it possible to sustain this, or is this a one-off thing? So hopefully now you will be seeing a graph. And this looks at our outcome data over the years. On the left is the preconception care rate, in the middle congenital abnormality rate, and the right stillbirth rate. So,
sorry, can't see your slides.
Okay, they're shared, it's not worked. So here we got preconception care rate, congenital abnormality rate in the middle, and stillbirth rate on the right. The purple bar in each of these groups represents the baseline 2002 to 3 data, and the rest from 2011 onwards. And as you can see, we not only doubled the preconception care rate, but sustained it. Sustained the improvements in congenital abnormality, and overall our stillbirth rate ran at around 1%. While we were developing PROCEED, we were acutely aware that the numbers in our clinic were growing. And if you look at our activity here, which is year by year, the green bars look at the number of people with pre-existing diabetes, which were gently increasing, whereas those with gestational diabetes increased exponentially. You can tell where we changed our guideline. We adopted the NICE guidance in 2015, following which there was a sharp rise in numbers. At this time, we were undertaking a service in a single antenatal clinic, the so-called Wednesday morning clinic that frequently went on to the middle of the afternoon. And we weren't in a position, I'm sure, that we were providing good quality care at that point. So when I tried a business case based on capacity, I was met with a blank, because one of the difficulties with this service is that the resources were needed were from the diabetes team to support glucose, yet the funding from the service came through the maternity streams. And women with gestational diabetes, of course, were labelled as lower risk as they first came into the pregnancy. So at that time, there really was no funding available. So we thought, well, what could we do within existing resources? So we decided to take some of the stable and lower risk people out face-to-face appointments and support them in between appointments by phone, which of course we had to do in our own time, but also at that point we didn't have a robust way of viewing glucose remotely, and so we relied on people reading out their glucose results or telling us everything was all right, only to find out a few weeks later that it wasn't. So far from ideal, but it did offload the clinic slightly. And I kept trying, and I think the maternity manager got to the point when she saw me, she'd scuttle off in the opposite direction down the corridor. But Thomas Edison said, our greatest weakness lies in giving up. And the most certain way to succeed is always to try just one more time. And the one last opportunity came following the Embrace report, Saving Lives and Improving Mothers' Care. And there was a funding opportunity through the maternity stream that would allow us to revise our antenatal service to cope with the numbers that we're seeing. When we undertook the service revision, we placed a lot of emphasis on risk stratification. So at one end, the highest risk people, I'm sure you would agree, are those with complicated pre-existing diabetes, the women with impaired renal function, hypertension, Charcot, so on. And at the other end are the lowest risk with gestational diabetes, who are on diet, metformin, with no other comorbidities. So the challenge is to give the attention to the people with the complex needs while keeping the lower risk people safe. So how did we do this? So for pre-existing diabetes, our pathway was that once women attended PROCEED, ideally, they would be managed remotely until they came for their 8-week viability scan. If control was suboptimal or they hadn't attended preconception, we set up an intensive glucose control clinic to support them. This was a clinic also that we could start off CGM in people with type 1 diabetes, and if they declined this or whatever other reason, we could initiate Freestyle Libre. So following that was the 12-week appointment, the dating appointment, and when they had their retinal screening. At this point, although it was multidisciplinary clinic, you would see different combinations of people, but the obstetrician and I made a point of reviewing these women so we got to know them and able to internally stratify the risks. Who did we really need to keep an eye on? Next up was 20 weeks, obviously, and at 28 weeks, they also had retinal screening again. And then had growth scans regularly. And in 36 weeks again, obstetrician and I made a point of seeing them jointly to compare what's been happening with diabetes, with the obstetrics, to start thinking about delivery, taking the woman's view on board. And as much as possible in between that, they were supported remotely or through nurse-led clinics, which streamlined the pathway compared with what it was before. But for gestational diabetes, we set up group sessions. These were midwife and dietitian led, where there were counsels as to the risks of gestational diabetes, taught home blood glucose monitoring, and given dietary advice. And then if they were expected to manage over the next few weeks just on diet and metformin with no other comorbidities, they were seen in a separate midwife and obstetrician led antenatal clinic, which had some dietetic support. And the rest were seen in the multidisciplinary clinic. And as with everybody else, they would have monthly growth scans from 28 weeks, and at 36 weeks, the start of a discussion regarding delivery. Now, in these situations, we almost exclusively manage these women remotely. We tried to implement GDM Health, which I will tell you about later, but we were not able to do so. But we took it a step further in that we asked women to upload their glucose meters or at least take a photograph of their book and email it to us on a generic email. So we did have some objective review of their glucose results. So I think when you undertake a system service change, that you do need to ensure that you're maintaining quality. And for us, this was partly done by our midwife, who kept an eye on these women to ensure that they did have appointments in a complex pathway, that they didn't get lost. We continued to collect our national audit data and the outcome data that I've shown you previously. But in addition, we wanted to undertake some quality improvements. We were fortunate to be one of 18 centres to be selected to be part of a quality improvement, a collaborative. And we chose a few areas that we wanted to focus on. There were a couple of areas of our own data out of the audit that we wanted to improve. Firstly, we appear to have a low rate of folic acid uptake preconceptually, which was rather odd since we were seeing 60% of women beforehand. So we wanted to increase the percentage of women conceiving on folic acid 5 milligrams from 34 to 50%. To increase the percentage of women having a third trimester HbA1c, we were performing poorly on that from 5 to 75%, and also increase the number of women accessing pumps. So we undertook root cause analysis for the first of the two of them, and we were taught to set up these diagrams called driver diagrams to help inform quality improvements. So you take each component of why the folic acid wasn't being taken up at the time the woman booked, and that could be that there was an initial problem with the prescription, that it wasn't continued, or that it was continued but not accurately documented. These are obvious, but if you break it down, you can then address the whys. So for the initial prescription, it was usually either clinician or user unawareness, or it may be a communication thing. So the awareness is easy to address. I use every opportunity, put it in structured education. Now, our communication was largely using a shared GP system, System 1, and we could communicate electronically with the practices. But not all practices had this, so we did generate some letters, and we made a point of putting the request to prescribe in bold when we sent these letters through. So we addressed the other points similarly. So the next thing we were taught to do is something called a run chart. Normally when you undertake service improvement, it's the PDSA, Plan, Do, Study, Act cycle. So you implement something for a fixed period of time, audit at the end of that, and then reflect on it and change again if necessary. But the run chart allows you to continuously evaluate your improvements so you can see benefits in a shorter period of time. So this is our folic acid run chart. On the x-axis is number of weeks. On the y-axis is the number of people seen since the last contact, since the last person who was on folic acid 5 milligrams. So the lower the number, the better. You've got more people on folic acid. In this, the vertical line represents the time at which we started implementing the changes that we derived from the driver diagram. The horizontal black line represents the median from the data before we started the intervention. And the objective is to get your time points to cross your line and to stay below the median. And as you can see, we achieved this with folic acid. We could see very quickly within a few weeks that we were improving the uptake of folic acid, or that audit parameter would be improved, because a lot of this was in fact about documentation. So if we look at the quality improvements that we used as a result of PROCEED and the service revision in our antenatal service, we were seeing approximately 60% of women preconceptually. Overall, our congenital abnormality rate has run around 3%, which is a bit higher than we would like. Stillbirth rate is hard to judge, as I said, because of small numbers, but is running at 1%. Again, that's above background, but better than the 6% we were seeing before. And we have increased preconceptual folic acid uptake from 34 to 58%. And the percentage of women who've delivered having a third trimester HbA1c from 5 to 85%. And 25% of the women with type 1 diabetes are on pumps. All our women are offered CGM. So as we considered what aspects we wanted to refine further, we met up with our third challenge, COVID-19. So clearly this has hit us all hard, and there were so many questions that we needed to answer to know how to deliver our service. What's the effect of COVID on diabetes, COVID on pregnancy? What diabetes services were we going to be able to continue? What maternity services were we going to be able to continue? And would we have to make any changes? So this was an early image, wasn't it, in COVID, a rainbow, and we're all in it together. And I felt certainly professionally this was very much the case. There was a great galvanizing of organizations and services to try and provide us some guidance. The charities, people were looking at data initially from China, and then as the data came from the UK, adapted it locally, advised us to how to structure our services, what the priorities were. So just considering a few of these. This data was published in The Lancet in April, and it looks at age on the x-axis and mortality on the y-axis. The turquoise and purple lines represent the non-diabetes and overall data, and shows what you know already, that age is a factor behind the mortality associated with COVID. But then if you add on the blue line for type 2 diabetes and the red for type 1, you can see at every age bracket, the mortality from diabetes is higher. Now, I know that in absolute terms, the age bracket that we are talking about today is low, but nevertheless, we do need to keep these women as safe as we can because of this. I've been struck of the metabolic derangement that we're seeing in diabetes as a result of COVID. Severe ketoacidosis requiring much higher insulin doses than we would normally use, not just in type 1, but we're seeing this in type 2 as well. In addition, we're seeing hyperglycemia in people without diabetes as well. So quite significant consequences with diabetes as a result of COVID. What about pregnancy? The Royal College of Obstetricians and Gynecologists put out some statements quite early on that fortunately pregnant women are no more at risk of contracting COVID than somebody who's not pregnant. However, if they do contract COVID, then there's a risk of more severe illness in later pregnancy. So the third trimester ITU admission rate, for example, is higher. There's an increase in preterm birth and caesarean section rates, but no evidence of congenital abnormalities, stillbirth, neonatal death, or effect on growth, which is very positive. And an American study of 1,481 births, 116 or 8% mums were COVID positive, but reassuring none of the babies were positive, even on repeat testing. So that's the impact of COVID on diabetes and pregnancy. What about services? We got guidance very early on from the charity Diabetes UK and the Association of British Clinical Diabetologists, who gave us some guidance as to what needed to be maintained and what could be put on hold. And as you can see, not surprisingly, diabetes antenatal services were one of the essential services. And as diabetes teams contemplated the challenge of COVID, how to manage these patients with COVID, how to prevent their admission and to continue the essential services, we were faced with additional challenges that the people we were looking after, particularly in the first wave, were absolutely terrified and didn't want to attend. And in addition, amongst diabetes teams, staff were being redeployed to acute wards. Some of these felt quite stressed by this. One of our nurses was redeployed to intensive care and a large percentage of her patients died and she went off sick. So from week to week, we didn't know what team members we would have to deliver services. It was apparent quite early on that in whatever service we were going to work in, that remote consultations were going to be the way forward. And we were fortunate in that we were making these already and had started to develop them. But there was extensive guidance produced as to how these could be done optimally. This is one example, the primary care diabetes guidance and how to undertake remote consultations for diabetes. I'm not going to go into this today, it was just to show you that it exists. Then in terms of maternity services, obviously guidance as to how to undertake clinics and keep people as safe as possible. But there was this publication from the Royal College of Obstetricians and Gynecologists who felt that perhaps we should not be doing glucose tolerance tests for diagnosing gestational diabetes. They proposed, as you know, that we undertake an HbA1c and random glucose at booking. And should these be normal and the woman be at high risk, that repeated at 28 weeks. And additional screening as clinically indicated for heavy glycosuria for large gestational age babies or polyhydramnios as before. I have to say that in our population, I was a little concerned about this, and the SNAP audit made me realise that we were going to miss around 70% of people that we had diagnosed. And I sent an email around to my colleagues in the collaborative, and a couple of them also voiced concerns. And a colleague in Dudley similarly did an audit and realised that we'd be missing up to 77% of these women, but others were choosing to adopt these guidance. So we were quite split. I was influenced by this publication in July that was from HAPO data that looked at different criteria in different countries. And for the UK, they estimated that we adopted the Royal College guidance on GDM screening, that we would miss 80% of gestational diabetes. Now we know that HAPO, or hypoglycemia and adverse outcome study, looked at glucose in the non-overt diabetic range and showed us that that glucose increase, there was a morbidity in that there were more babies born over the 90th centile, higher primary caesarean section rate, and a neonatal hypoglycemia, as well as C-peptide in the cord blood being over the 90th centile. And there was also this paper that was published in 2019 that looked at 41 centres in England and found that the women who had a risk for gestational diabetes but hadn't been screened had a higher risk of stillbirth than those who were diagnosed with gestational diabetes. And this was particularly so for fasting glucose. So if these women who hadn't been diagnosed with subsequently found to have higher fasting glucose, they had a greater risk than women with GDM with a raised fasting glucose who had been diagnosed and managed. So interesting data. So we discussed this on a regional maternity network, and many of us chose to continue glucose tolerance testing because of data such as this, but this wasn't uniform at all. I do think it depends on your local population and the prevalence of gestational diabetes and the other pressures that you're under and whether you are able to do these many hundreds of glucose tolerance tests. So we felt that the Royal College guidance should be a minimum standard in our region, and that glucose tolerance testing, if possible and feasible and safe, should be continued. So we continued this because we did have the capacity to do this, but we undertook some changes. We clearly observed social distancing, but brought women in much earlier. So their glucose tolerance test was at 7:30. So they were out of the hospital by the time the main clinics got going. And we haven't had any cases of COVID as a result of doing glucose tolerance tests. So initially, we disbanded our group education, obviously concerned about risk. But then we felt that we weren't doing these women a service as we tried to manage new diagnosis of gestational diabetes remotely. We had access to an ward area that had 6 bays, and we could have 4 women in with 2 meters social distancing with the educator in the middle, and so we reinstated these groups. We undertook the risk stratification as we did before to the midwife-led or MDT clinic, but they only attended when they came from scan. We were quite clear about that. And one of the things I've observed that you come across many layers of bureaucracy in your journey in service development in the NHS. But when a crisis such as COVID comes along, sometimes they do fall away to your advantage. And this was the case with GDM Health for our perspective. And we were able to undertake management remotely with GDM Health and keep people safe. I don't know whether you all know about GDM Health, but I'll just explain for those who don't. This is an app that works with the WaveSense Jazz meter at present, but the company are considering broadening the spectrum of meters that it's compatible with. So the person with GDM downloads an app, and the WaveSense Jazz uploads the glucose to the app, and they are able to share their glucose results to us. We access GDM Health through a web-based platform. We can see the individual patient's results, and you can see that in the picture that's behind the phone. And we can message the woman, we can phone them up and advise on treatment changes remotely, and they can contact us and request a discussion. So our homepage is a dashboard where all the women who are actively engaging in diabetes management are listed. And if their glucose is consecutively out of target, they will flag. So we can look at these patients on a daily basis and highlight those that are needing adjustment in their treatment proactively. So it's an excellent way of managing large numbers of people remotely. In terms of pre-existing diabetes, we continue to proceed, but undertook this at a remotely, and we used video consultations, which we call AcuRx. So AcuRx was designed for primary care use, but is available in secondary care. So you can see this small box sitting on the GP record. It pulls in data from the NHS spine. It allows you to text the person securely and for them to respond, and a record of that goes in the electronic records. You can attach documents, so you can have summarize the points of your consultation and attach an information sheet or guidance. And it does support video consultations for up to 4 people. I feel that the first consultation for PROCEED and the risk discussion can be quite emotive, and to be able to see the person is ideal. It should be face-to-face, but when we're not doing that, then the video consultation through AcuRx is ideal. And we are able to talk to the couple and not just the woman on her own. So a tool that I really like, that I use a lot, not just in the preconception period, but for the integrated diabetes care in any case. So in terms of the antenatal pathway, in a similar way to gestational diabetes, women only attend from scan. one of the things that was interesting from my personal perspective was that I was in the high risk category in the first wave, so I wasn't able to come to clinic. I had to work from home. I wanted to continue to do antenatal clinic. So we thought of a way I could do this. So I dialed in on Microsoft Teams, and I was logged in onto a laptop on wheels in the middle of the consulting room, where I could see the obstetrician and the patient as well, and was able to have access at home to all the systems that I needed and the remote management tool, that the glucose management tool that the patient was using. So I was able to undertake my consultations. They coped with it incredibly well, and some of them actually gave us quite positive feedback, and they said, oh well, you know, if you were in the room, there'd be 4 of us in the room, we won't be able to social distance, this is much safer. And we've actually continued this for now. Ultimately, clearly, we'll go back to face-to-face consultations for the multidisciplinary in all probability, but it certainly worked for me. The remote management is using tools that you'll all be familiar with. I've described just GDM Health, which we use for type 2 as well as gestational diabetes. Those on Libra, it's LibraView, Dexcom Clarity, or Diascend. Now, postnatally, for women with gestational diabetes, we've been giving them a form for HbA1c to be done at 12 weeks. And we suggested they put a note on the baby's red book at 12 weeks, remember to go for my blood test. And we were picking up, and we were chasing these results and writing to women. We were picking up 60–65% without having to chase them. But that number is now halved because of COVID. I think the logistics are difficult. They're having to make appointments online. They can't go to have it at the same time as the baby's check. And it's something that we will need to address. For pre-existing diabetes, we've always reviewed them around 6 weeks by telephone through Proceed, because in our experience, women have very different needs. It's an opportunity to counsel women on the need for preconception care if they hadn't previously engaged, talk about contraception, ask them what support they need for their diabetes, signpost them to their services accordingly, and reinstate their routine care. And again, we've used AccuRx for this. So that's what we're doing in COVID. What about the future? And I'm sure you'll all agree that COVID has given us the opportunity to use different ways of working, and some of these will be here to stay. And I certainly think a lot of remote consultations will be here to stay. But there'll always be a digital divide and a need for face-to-face consultations. And some people it will not be suitable for example, those with learning disabilities. Similarly, we've had the opportunity to undertake webinars like this that allow us to learn from each other and reach many people. I was invited a few weeks ago to give a webinar that reached people in India, Myanmar, and Nepal simultaneously. It was an amazing experience. But I'm sure you also agree that there's no substitute to meeting face to face, because the value of networking at lunchtime and coffee breaks is absolutely immense. So some of these will stay. And to conclude, I have demonstrated how we've improved the uptake of preconception care, described how we maintained quality and managed increasing numbers, and explained how we managed our service during the COVID pandemic. So thank you, apologies for the IT failure. Thanks.
Hi, Parry, that's brilliant. Thank you very much. If I could also invite Sarah back on screen, and also John Hughes from Advanced Therapeutics, in case you have any questions for him as well. I've got a couple of questions for you, Parry. The first one is, what are the preconception strategy you advise for GDM mothers in their previous pregnancy?
I think what we forget about is often weight. These are people with GDM who've subsequently got completely normal glucose. I think I didn't put up a slide looking at components of preconception care, but one of the most important ones is looking at the lifestyle type changes for all women planning pregnancy. And they apply particularly for women with gestational diabetes because they are often overweight. And we forget that obesity carries the same risk factors as diabetes. There was a confidential inquiry done on the subject. So when I see them at 36 weeks, I do emphasise and it's an opportunity for diabetes prevention, signposting them to the prevention programme and really making a difference. I tell them that we've had women who have successfully lost weight and they've not had gestational diabetes the next time, and the massive potential to prevent diabetes in the future. So I think that's one of the things that we do. And I think we do counsel them on general things like alcohol avoidance, smoking cessation, and so on. I think women who've had gestational diabetes but then do not have normal glucose, we invite them to attend the preconception clinic and we would get them monitoring early.
Okay, fantastic. Thank you very much. So the next question is, are you recommending low dose aspirin from 12 to 40 to 36 to 40?
So we recommend low dose aspirin for all people with pre-existing diabetes from 12 weeks.
Brilliant, thank you. Are there any national audits for the new method of screening GDM in COVID era?
Not that I'm aware of. I think it's very interesting. I think we should audit this retrospectively for particularly the centres who have chosen not to go down the Royal College guidance. It was something that we were discussing at a national level recently. The steps haven't been put in place, but I think it would be very interesting for local centres to undertake these audits.
Brilliant, thank you. So someone else has asked, have you used any particular guidelines to help you set up the GDM groups again, or is it just trust specific?
The GDM groups, I know that there are other centres that undertook GDM groups, and I said the value of attending meetings is the networking and the chit chat. So the National Diabetes and Pregnancy Meeting provides that that networking opportunity. And I talked to various people, and we had discussed setting up groups. So there wasn't a formal curriculum that's available nationally, but clearly we have on our template a list of things that we need to cover, and certainly the dietitian who supports that group has got extensive experience in developing education and was able to formulate a package that seems to have worked for our ladies.
Okay, brilliant. Is there any specific training materials available when introducing CGM into practice for maternity and neonatal staff?
Well, I think that management of CGM really is quite a specialist area and should be undertaken by the diabetes team. And I think the diabetes team should be making themselves available to support these women. And our women have open, access to us even if they're in hospital. I think maternity teams need to know what it is and how to access us. There's plenty of material available online, and particularly through the ABCD website on Libra and CGM for people to learn. We do cover it in principle on the education that we do for all our midwives, but it is very much that this exists. And the current national recommendation, it should be offered for everybody with type 1 diabetes for 12 months. And we do interrogate this system using web-based platforms. So if somebody's in, then do get hold of us, and we're happy to support these women.
Okay, brilliant. So someone's asked about guidelines in relation to setting up groups during COVID. So kind of group numbers and spaces between women. Have you used any specific guidelines for doing that?
I've not seen any guidelines about groups in COVID, but clearly there is guidance about outpatients and social distancing, and we did tick those boxes.
Okay, brilliant, thank you. Do you carry out GTT test at 34 weeks if results are normal at 28, and if there is evidence of high glucose?
If for glycosuria, if a glucose tolerance test was done earlier on because of glycosuria, I do not undertake a further glucose tolerance test unless the level of glycosuria increases. I am very reluctant to undertake a glucose tolerance test after 34 weeks. So I'm not sure if you get a marginally abnormal result, how you interpret that, because everybody's glucose tolerance declines, reaching a peak at 34 weeks. My preference, if there really is an index of concern, they tend to be run by myself and our specialist midwife, we would do a week's monitoring rather than a glucose tolerance test.
Okay, that's brilliant, thank you. We've just got a couple more questions. If anyone has any questions for Sarah or John, as well as Paro, do just send those into the Q&A box and we can get those answered for you. So, is there any funding to set up GDM health service in COVID times?
There is. We're not paying for it at the moment. It's free this year. So if you approach the company, I mean, the limiting factor, it's not a service that's improved by NHS Digital in the way that AccuRx is. And our trust had concerns about the security, and they employed somebody to probe it and check that the security was adequate, which it was. And I think that would be the barrier rather than funding at the moment.
Okay, that's brilliant, thank you. Sarah, John, did you have anything to add?
From me?
Okay, that's brilliant. Well, okay, well, that is all the questions that we've got, and we're right on time as well. So I would really like to thank Advanced Therapeutics, Agamatrix for sponsoring the webinar, and Sarah as well for delivering the informative presentation. And thank you so much, Paro, for your wonderful presentation and answering all those questions brilliantly. So thank you, and I hope you all enjoyed it.